Good evening, Dr. Phil here. Today we'll be discussing on opioid pharmacodynamics. Inhibitory effects. Analgesia. Analgesia from opioids is the result of agonist activity at MOP, KOP, and DOP receptors. This is the pain pathway. Peripheral nociceptors stimulated by tissue damage transmits nociceptive information to the spinal cord by slow conducting unmyelinated C fibers, which causes dull burning pain, and faster thinly myelinated A delta fibers, which causes sharp pricking pain. This table summarizes the different types of nerve fibers. Most nociceptive A delta fibers and C fibers enter the dorsal horn of the spinal cord and terminate superficially in the laminae 1 and 2. A small number of these fibers terminate at deeper laminae. From these laminae, projections from neurons give rise to the ascending pathways of the spinal thalamic tract. Thalamic nuclei receives the nociceptive inputs and passes the information to the periaqueductal gray or PAG, amygdala, somatosensory cortex, and other brain pain reception sites. Pain modulation occurs via gate control theory at the dorsal horn of the spinal cord and descending inhibitory pathways. This is a simplified diagram of the descending pain modulatory system. Green lines represent the activated descending inhibitory pathways. Red lines represent afferent nociceptive input. Descending inhibition is activated in multiple areas such as the rostral ventromedial medulla, periaqueductal gray, amygdala, cingulate cortex, insula, orbital frontal cortex, etc. Agonist activity at opioid receptors that causes analgesia occur throughout the nervous system, resulting in supraspinal effects, effects at the spinal cord, and peripheral effects. Supraspinal effects occurs at the cortex, amygdala, thalamus, hypothalamus, brainstem, and other higher brain centers. Opioids exert actions in the cortex and limbic systems, affecting cholinergic systems that influence arousal and pain perception. Activation of MOP receptors located extensively at key higher brain centers stimulates analgesia by activating descending inhibitory pathways from the midbrain PAG, rostral ventral medulla, nucleus raffimagnus, and other centers. These descending inhibitory pathways inhibit nociceptive dorsal horn neurons firing in the spinal cord. Opioids modifies both nociception, which is the neural process of encoding and processing of noxious stimuli that can potentially or actually damage tissue, and pain, which is the subjective translation of noxious stimuli into a perception or sensation, i.e. emotional coloring of pain. Effects of opioids at the spinal cord for analgesia. Opioid receptors are abundantly present in the dorsal horn of the spinal cord at pre- and post-synaptic locations. Activation of these opioid receptors causes inhibitory effects within the dorsal horn of the spinal cord, both pre- and post-synaptically, resulting in inhibition of release of various transmitters from primary afferent terminals in the dorsal horn, reduction of excitability of dorsal horn neurons, inhibition of nociceptive impulses through the dorsal horn of the spinal cord, and inhibition of nociceptive spinal reflexes. Local neuronal circuits in superficial laminae of the dorsal horn processes both ascending and descending pain pathways and are regulated by local endogenous opioid circuits. Peripheral effects. During inflammatory states, MOP receptors modulate immune function and nociceptors that are important in regulating peripheral sensitization of pain. Opioid receptors are located at neurons and immune cells. Local inflammatory cascades induces spontaneous nociceptor activity, sensitizing sensory neurons to produce spontaneous pain, allodynia, and hyperalgesia. Leukocytes that flood sites of inflammation are themselves a major source of endogenous opioid peptides. Leukocytes release opioid peptides locally to induce analgesia. Inflammation stimulates opioid receptor upregulation as well at the site of inflammation. Overall, inflammatory processes promote inflammation and its painful sequelae, and initiates and sustains a counteracting analgesia driven by endogenous opioids. Opioids reduce the discharge of nociceptive efferent terminals in the periphery, A delta and C fibers, especially during inflammation, where the expression of opioid receptors by sensory neurons is increased. For example, following surgery to the knee joint, injection of morphine into the knee joint provides effective analgesia. Opioids are highly effective analgesics for acute pain and cancer pain, but are less effective for neuropathic pain and other chronic pain syndromes. Continuous dull pain is relieved by opioids more effectively than sharp intermittent pain. Opioids are effective against deep visceral pain. More effective pain control is achieved when opioids are administered prior to the painful stimulus. Individual variability of analgesic response to opioids can vary by as much as 20 times due to variability in pharmacokinetic related parameters, which is affected by age, gender, weight, body fat and muscle content, renal or liver function, cardiac output, genetic polymorphism, and co-medication. Variability of analgesic response to morphine can be due to mutations in a number of genes, including that for the drug transporter P-glycoprotein, glucuronil transferase that metabolizes morphine, and genetic polymorphism of MOP receptors. The metabolism of codeine, oxycodone, methadone, tramadol, and dextromethorphan are affected by mutations of various CYP enzymes. Kindly refer to the video on pharmacokinetics of opioids for further details. The variation for response to opioids is also the result of variability in pharmacodynamic related parameters. Altered sensitivity of opioid receptors can occur due to genetic variability. Individual variability in the response towards opioids can also be attributed to the ability to score pain, which depends on various factors that affects the function of brain areas involved in the translation of nociceptive stimuli into a verbal numeric response, including the presence of chronic pain, which causes neuroplastic changes in the frontal and parietal cortices, prior to opioid administration, which causes transient effects on cognitive and signal processing, etc. Clinical significance. This individual variability is not restricted to morphine but is observed for all opioids used for the treatment of acute, perioperative, and chronic pain. The safest approach to opioid analgesia is to carefully titrate to analgesic effect, with awareness of the undesirable dose-related side effects. For intraoperative pain control, titrate opioids in doses sufficient to dampen or prevent exaggerated hemodynamic responses to painful surgical stimuli. Potent high-dose opioids such as remifentanil and fentanyl are the opioids of choice for intraoperative pain control. Be wary of hypotension and bradycardia. For post-operative pain or chronic pain control, titrate opioids to the patient's verbal response to pain. Medium-strength opioids such as morphine and methadone are the opioids of choice. Be wary of respiratory depression, severe sedation, nausea, vomiting, and ileus. Opioids causes suppression of stress response to laryngoscopy and airway manipulation. They inhibit the pituitary adrenal axis and may reduce plasma concentrations of catecholamines, cortisol, and other stress hormones. Opioids reduces central sympathetic outflow and influence central neuroendocrine responses. The next inhibitory effect is sedation and sleep. EEG changes due to opioids are progressive decrease in EEG frequency, production of delta waves. However, burst suppression is not seen even with large doses of opioids. Effect of opioid on sleep. Opioids interfere with rapid eye movement sleep. Opioid-related respiratory depression is more common during sleep. Effects of opioids on MAC. A dose-related reduction in minimum alveolar concentration for volatile anesthetic occurs with opioid administration, though there is a flaw to this effect. However, opioids alone do not act as reliable anesthetic agents. Opioid as a sedative. Opioid-induced sedation may be used therapeutically, for example, in sedation of critically ill patients. Opioids reduce the requirements for inhalational and intravenous anesthetic agents during anesthesia and makes rapid awakening from anesthesia possible. For example, patient awakening occurs within 6.5 minutes after termination of propofol and remifentanil infusions at plasma concentrations of propofol 1.5 microgram per ml and remifentanil 9.0 nanogram per ml. Respiratory depression. This is the commonest cause of death in acute opioid poisoning. Reported post-operative opioid-induced respiratory depression has an average incidence of 0.5% and ranges from 0.2 to 2%. However, respiratory depression from opioids frequently goes undetected and is therefore underreported. Randomized control trials which used morphine as a positive control demonstrated the incidence of morphine-induced respiratory depression, defined as a respiratory rate of less than 8 breaths per minute, occurs in as high as 30% of patients during PCA morphine treatment. This also applies for opioid treatment for chronic pain. Deaths from accidental opioid overdose may be falsely attributed to progression of the underlying disease in chronic cancer patients. Respiratory depression is mediated by MOP receptors. Opioids cause respiratory depression by causing a depression of sensitivity of neurons on the ventral surface of the medulla to PaCO2 levels, even with small doses of MOP agonists. Normally, increases in PaCO2 is detected by chemosensitive neurons in a number of brainstem and medullary nuclei and results in a compensatory increase in minute ventilation. Opioids depresses this hypercapnic response, and increases in minute ventilation becomes insufficient to counteract the increase in PaCO2. Inhibition of the respiratory response to hypoxia. Opioids blunts central chemosensitivity to hypercapnia and hypoxia at the levels of the retrotrapezoid nucleus, medullary raphe nucleus, and nucleus tractus solitarius. Opioid-induced decreased efferent input into the brainstem from peripheral chemoreceptors causes a reduction in tidal volume. Inhibition of respiratory rhythm generation. The ventral respiratory group contains the pre-Botzinger complex, which establishes the basic rhythm of respiration. MOP opioid receptors are located in this region, and local injection of opioid agonists has demonstrated reduced respiratory frequency. Tolerance to opioid-induced respiratory depression does occur with chronic opioid use. The degree of respiratory depression produced may be less than anticipated in patients with severe pain. Speed of opioid injection. Careful, slow infusion of opioids allow a gradual increase in PaCO2. Increase in PaCO2 provides stimulation at the chemoreceptors and subsequently the respiratory center and lowers the probability of apnea. Monitoring of the respiratory rate and oxygen saturation will appear as if opioid injected has no effect on the ventilatory system, but the opioid effect becomes visible on end-tidal CO2 monitoring or arterial blood gas. However, serious perioperative respiratory depression still occurs at around 0.5%. Rapid injection of potent opioids. A rapid depression of respiratory neurons occurs as the opioid crosses the blood-brain barrier. There will be no time for gradual CO2 accumulation, resulting in an apneic patient. Upper airway collapse occurs due to suppression of neurons in the brainstem involved in maintaining the upper airway muscle tone, or from the loss of muscle tone related to sedation. Thus, opioids may increase the collapsibility of the upper airways. This results in increased central and obstructive apneic events that may cause recurrent hypoxemia, especially in certain patient groups such as post-operative patients on PCA morphine. Risk factors for opioid-induced respiratory depression includes general risk factors such as elderly, neonates, opioids given without titrating effect to analgesic response, when nociceptive input is suddenly reduced or removed, for example after a nerve block after opioids were given, sleep-disordered breathing, obesity, renal impairment, pulmonary disease, neurologic or neuromuscular disorders, and CYP450 enzyme polymorphism, for example, ultra-rapid metabolizing individuals having multiple copies of the CYP2D6 gene. Pediatric risk factors include morphine administration in patients with renal impairment, adenotonsillectomy for recurrent tonsillitis, obstructive sleep apnea, and codeine use in patients with the ultra-rapid metabolizer phenotype due to CYP2D6 gene polymorphism. Risk factors among chronic pain patients includes chronic opioid user, renal failure, sensory deafferentation, and drug-drug interactions. Monitoring. Spot oxygen saturation measurements by regular nurse visits are insufficient to detect or predict the occurrence of respiratory depression due to opioids, and can seriously underestimate the presence, duration, and severity of post-operative hypoxemia. Post-operative respiratory depression or obstruction are often episodic. Arousals and hyperventilation occurs in between events. This causes repetitive triggering of the oxygen saturation monitoring alarm and possibly alarm fatigue of nursing staff. Monitors that directly indicate breathing activity are preferable to oxygen saturation monitoring, and includes monitors that indirectly measures expiratory flow, such as EtCO2 and humidity. These devices gives a reliable estimate of breathing frequency. These monitors will alarm in the event of airway obstruction, where flow rate is zero, and reduced breathing rates. Regarding treatment, a future video on opioid antagonists will be made. Mood effects of opioids. Euphoria. Significant euphoria is uncommon when opioids are used to treat pain. However, euphoria occurs frequently when opioids are used abusively and is mediated through MOP receptors. Dysphoria is mediated through KOP receptor activation. Antagonists at KOP receptors have antidepressant properties. Hallucinations are mediated through KOP receptor activation. Hallucinations are typically visual in nature and may only affect part of the visual field. Myoclonic jerks, sedation, and hallucinations can occur in cases of opioid toxicity. Opioids also causes anxiolysis. Cognitive dysfunction from opioids includes memory loss and inability to concentrate or focus attention. Opioids also suppresses cough activity and mucociliary function. The mechanism of the antitussive effects of opioids is unclear at the receptor level. Opioids' antitussive activity, at least in part, is mediated peripherally and is exacerbated by associated sedation and respiratory depression. This may result in inadequate clearing of secretions and hypostatic pneumonia. Opioids-induced cough suppression does not correlate with analgesic and respiratory depressant actions of opioids. Excitatory effects of opioids. Meiosis. Opioids causes MOP and KOP receptor-mediated stimulation of the oculomotor nucleus. This is a useful clinical feature in diagnosing opioid poisoning, except for petidine, which causes pupillary dilation because it blocks muscarinic receptors. Tolerance does not develop to opioid-induced pupillary constriction, and meiosis is still present with chronic opioid use. Nausea and vomiting occurs in up to 40% of patients to whom morphine is given. Central and peripheral actions by opioids causes nausea and vomiting by direct effects on the chemoreceptor trigger zone area postrema, direct effects on the GI tract, for example by causing delay in gastric emptying. Opioids causes an increased sensitivity of the vestibular system, which can be stimulated by movement, such as during patient transport. Nausea and vomiting due to morphine are usually transient and decreases with repeated administration. Adverse effects of post-operative nausea and vomiting includes patient distress and dissatisfaction, pulmonary aspiration, post-operative pain, wound dehiscence and hemorrhage after eye, head and neck, esophageal or abdominal surgery, dehydration, electrolyte imbalance, and/or requirement for intravenous fluids. Delayed oral intake of medications, nutrition, and fluids, delayed mobilization, and delayed discharge from hospital. Useful prevention strategies for post-operative nausea vomiting: use propofol rather than inhalational anesthetics, use regional post-operative analgesia rather than intravenous opioids, multimodal antiemetic therapy given prior to the end of surgery, including serotonin antagonist, dopamine antagonist, and a steroid. Opioids causes reduced motility in many parts of the GI tract. Opioids causes increased activity in circular muscles of the bowel, which prevents effective peristalsis, resulting in constipation, delayed gastric emptying, bowel distension, and paralytic ileus. Mechanism: peripheral mechanism. As the increase in tone is reduced or abolished by atropine, it is inferred that the action of morphine on visceral smooth muscle is probably mediated mainly through the intramural nerve plexuses. Central mechanism. Evidence for a central mechanism is indicated by inhibition of propulsive gastrointestinal movements seen after intracerebroventricular injection of morphine. Opiates such as codeine and morphine has been used to treat diarrhea as they reduce GI motility. Blockade of opioid receptors with opioid antagonists that do not cross the blood-brain barrier such as methyl naltrexone improves GI motility. Opioids causes increased biliary pressure with gallbladder contraction and constriction of the biliary sphincter. Avoid opioids in patients with biliary colic as pain may increase rather than decrease. Increased intrabiliary pressure may result in transient increase in serum amylase and lipase. Opioids may cause misinterpretation of perioperative cholangiograms. Naloxone or glucagon can be used to treat opioid-induced spasms of the sphincter of Oddi and the common bile duct. Opioids causes increased smooth muscle contraction at other sites and may result in urinary retention and urgency, bronchoconstriction, and spasms of the ureters, bladder, and the uterus. Urinary retention and urgency is possibly related to opioid-mediated central effects, as these problems are more common with neuraxial opioids. Activation of opioid receptors present in the wall of the bladder and ureters can cause acute urine retention by causing smooth muscle contraction of the urethrosphincter and bladder. Urethrosphincter muscle is unable to relax while the bladder tone increases. This is treated with opioid antagonists. Other opioid effects. Histamine release. Histamine release from mast cells is caused by morphine, but not by phenylpiperidines such as fentanyl. This effect may not be mediated by MOP receptors, as it is not reliably reversed by naloxone. Local effects include pruritus and urticaria. The nose, face, and torso are particularly affected. Systemic effects include tachycardia, reduced systemic vascular resistance, reduced arterial pressure, and bronchospasm. Cardiovascular effects. If opioid-induced histamine release occurs, then there may be tachycardia, reduced systemic vascular resistance, and reduced arterial pressure. However, the majority of opioids have no significant cardiovascular depressant effects in normal volemic patients. Opioids reduces central sympathetic outflow. In patients who are relying on increased sympathetic tone to maintain cardiovascular stability, opioids may lead to worsening shock, particularly if potent opioids are given by rapid intravenous bolus. Opioids causes reduced vascular smooth muscle tone. Bradycardia. Large doses of most opioids causes bradycardia and hypotension due to stimulation of the vagal nuclei in the medulla and direct depressant effects on the sinoatrial node. Opioids have no direct action on baroreceptors. Reductions in preload and afterload may occur during bradycardia. Opioids have no effect on cerebral blood flow autoregulation. However, if respiratory depression is present, then the resultant increase in PaCO2 may increase cerebral blood flow and potentially increase ICP. Effects of combinations of opioids and anesthetic agents on cardiovascular stability. Morphine or fentanyl plus nitrous oxide or benzodiazepine results in cardiovascular depression, which does not occur when either drug is administered alone at typical doses. This is manifested as reduced cardiac output, reduced systemic blood pressure, and increased cardiac filling pressures. Opioids have been increasingly recognized as playing a role in myocardial protection from ischemia via KOP and DOP receptor activation. Skeletal muscle rigidity. Muscle rigidity is associated with rapid injection of potent short-acting opioids. Proposed mechanism. Opioids cause simultaneous inhibition of GABA release in the striatum of the basal ganglia, together with a simultaneous but transient increase in dopamine production. Skeletal muscle rigidity may occur at thoracic, abdominal, and pharyngeal muscles. Chest wall rigidity causes reduced respiratory compliance and difficulty in ventilation. Measures to minimize chest wall rigidity due to opioids. By co-administration of opioids with intravenous anesthetic agents and benzodiazepines, reversal of opioid effects by naloxone, and prevention of muscle rigidity by neuromuscular blocking agents. Tolerance. Tolerance is defined as the requirement of increasing doses of a drug to achieve a given pharmacological effect. Mechanism of tolerance. Tolerance is caused by a progressive loss of active receptor sites combined with uncoupling of the opioid receptor from the guanosine triphosphate binding subunit. Beta-arrestin dependent receptor desensitization and internalization occurs. Tolerance can be detected even with a single dose of morphine in animal studies. The NMDA receptor may also play a role in acute opioid tolerance via protein kinase C activity, lifting the magnesium block at the NMDA site. NMDA receptor antagonists such as ketamine can therefore be used for analgesia during acute opioid tolerance. Other mechanisms involved in opioid tolerance includes interactions with the NOP receptor and long-term adaptive changes at the cellular, synaptic, and network levels. Incomplete cross-tolerance between different types of opioids exists and may result from their differential activity at opioid receptor subtypes. Effects of morphine significantly affected by opioid tolerance includes analgesia, emesis, euphoria, and respiratory depression. Constipation and pupillary constriction is less affected by tolerance. Presentation of opioid tolerance. There is a progressive lack of response to opioids and increase in opioid requirement. Pain improves with increased opioid doses. Unusually high doses of opioids might be needed. There is no increased pain sensitivity over time, assessed by serial quantitative sensory testing. Acute opioid tolerance is due to tachyphylaxis. Patient requires increases in doses of opioids to reach a defined analgesic endpoint during the initial hours of opioid treatment. Chronic opioid tolerance is often seen in opioid abusers and occurs over many days. It presents as a decreasing analgesic effect, resulting in dose escalation and increased likelihood of OIH, or opioid-induced hyperalgesia. Pseudotolerance is seen in chronic pain patients. It is due to progression of disease with increased nociception due to destruction of nerves in the tumor region if it's due to cancer. This results in neuropathic pain which is poorly responsive to increases in opioid dosage. Clinical relevance of opioid tolerance. A significant number of patients are receiving long-term opioid therapy for malignant and chronic non-malignant pain and may be vulnerable to inadequate analgesia secondary to opioid tolerance. Fortunately, after initial dose titration, the majority of patients on long-term opioids are usually maintained on a stable dose. Drug rotation by changing from one opioid to another is used to overcome loss of effectiveness if present. Post-operative pain management of patients on long-term opioids. Due to opioid tolerance, illicit opioid abusers tend to require higher doses of opioids to treat their pain. During post-operative pain management, the aim is to provide good pain relief and prevent opioid withdrawal, but it is not the appropriate time to treat addiction. Background opioids needs to be prescribed to prevent withdrawal. PCA opioids provide good post-operative pain management. Consider background infusions. Alternative analgesia should be prescribed if there are no contraindications such as paracetamol, NSAIDs, and nerve blocks. Other substance abuse needs to be considered and substitutes prescribed if necessary. After patient discharge from the hospital, GP or specialist drug service should be informed for continued prescribing to be made. Opioid users who are tolerant to opioids may take up to 50 times the normal analgesic dose of morphine with relatively little respiratory depression. However, they still experience marked constipation and pupillary constriction. Tolerance may develop acutely, for example when opioids are used for pain control before surgery or when given intrathecally. However, tolerance typically develops within a few days during repeated administration. It is unknown how much cross-tolerance exists for different routes of administration, for example intravenous versus epidural. Opioid dependence and withdrawal. Physical dependence. This refers to a state in which withdrawal of the drug causes adverse physiological effects, and typically occurs when opioids were administered for more than a few days. A physiologic and biochemical adaptation of neurons such that removing a drug precipitates withdrawal or an abstinence syndrome. Physical dependence to morphine typically requires about 25 days to develop. Mechanisms involved in the development of opioid withdrawal syndrome. Opioid withdrawal may occur if there is an abrupt cessation of opioids or if an opioid antagonist is given. It is mediated by the MOP receptor. Spinal reflex hyperexcitability occurs. The rate of firing of noradrenergic pathways emanating from the locus ceruleus is reduced by opioids and increased during abstinence syndrome. Signs of opioid withdrawal typically last a few days after cessation of opioids. Includes sympatoactivation, anxiety, craving, agitation, abdominal pains, hallucinations, runny nose, diarrhea, shivering, pillow erection. Time course for opioid withdrawal. For Petidine, onset is 2 to 6 hours, peak intensity 6 to 12 hours, duration 4 to 5 days. For Fentanyl, onset is 2 to 6 hours, peak intensity 6 to 12 hours, duration 4 to 5 days. Morphine, onset is 6 to 18 hours, peak intensity 36 to 72 hours, duration 7 to 10 days. For heroin, onset is 6 to 18 hours, peak intensity 36 to 72 hours, duration 7 to 10 days. For methadone, onset is 24 to 48 hours, peak intensity 3 to 21 days, duration 6 to 7 weeks. Withdrawal symptoms can be reduced by alpha-2 adrenoceptor agonists such as lofazidine, long-acting MOP agonists such as methadone and buprenorphine, NMDA receptor antagonists such as ketamine. Withdrawal symptoms are less intense if opioids are withdrawn gradually. Examples of opioids that are less likely to cause dependence includes codeine, buprenorphine, and tramadol. Psychological dependence, also known as addiction, is the compulsive use of opioids to the detriment of the patient in terms of physical, psychological, or social function, and may last for months or years. Psychological dependence, also known as craving, is the main driving force and causes physical dependence to become more prominent. It rarely occurs in patients being given opioids as analgesics. Drug-seeking behavior does not necessarily equate opioid addiction if opioids were used appropriately for pain relief in both acute and chronic pain control. Opioid-induced hyperalgesia, OIH. Definition. This describes the paradoxical increased sensitivity to pain in subjects given opioids. Mechanism of OIH. It is not fully understood. Postulated theories are complex. All MOP receptor agonists may cause OIH. Examples of current theories. One theory suggests that metabolite morphine 3-glucuronide was an analgesic. However, this was an oversimplistic hypothesis that would limit the phenomenon to morphine-containing opioids alone, which is not the case. Another theory suggests that there is an alteration of the opioid receptor itself, such that the G-protein secondary messenger systems described undergo a switch from inhibitory to an excitatory coupled mode. Activation of the central glutaminergic system. Prolonged use of opioids may cause downregulation of glutamate transport at the spinal cord level. Increased glutamate and glutamate activation of NMDA receptors may augment the sensitization of spinal neurons. Descending inhibitory serotoninergic pathways may become pro-nociceptive. Changes in cytokine production, alterations in calcium channel functioning, activation of substance P, which is a neuropeptide at the spinal cord that mediates nociception via binding to the neurokinin 1 receptor, nitrous oxide and PKC receptor activation, upregulation of P2X4 receptor expression in microglia, resulting in BDNF release, TRKB signaling, and downregulation of the potassium chloride cotransporter KCC2. The presence of MOP receptor is not a prerequisite for OIH. OIH is associated with long-term and/or high-dose opioid treatment, rapid opioid dose escalation, and administration of an opioid with rapid onset or offset, such as remifentanil. High doses of potent intraoperative opioids can reduce nociceptive thresholds and causes secondary hyperalgesia. Presentation of OIH. There is increased opioid requirements. The patient has a reduced analgesic response to a given dose of opioid. Pain worsens with increased opioid doses. Increased pain sensitivity over time assessed using serial quantitative sensory testing. This table compares and contrasts opioid-induced hyperalgesia, opioid tolerance, and acute opioid withdrawal. Definition of OIH: paradoxical increased sensitivity to pain in subjects given opioids. Definition of opioid tolerance: a condition where there is a requirement of increasing doses of an opioid to achieve a defined analgesic endpoint due to tachyphylaxis. Acute opioid withdrawal refers to a state in which withdrawal of the opioid causes adverse physiological and psychological effects. Precipitating factors of OIH includes long-term and/or high-dose opioid treatment, rapid opioid dose escalation, administration of an opioid with rapid onset or offset. Precipitants for opioid tolerance: the patient received long-term and/or high-dose opioid treatment. Tolerance may develop acutely, for example when opioids are used for pain control before surgery or when given intrathecally. Precipitants for opioid withdrawal: abrupt offset of opioid effect, underdosing of opioid in patients chronically receiving opioids. Diagnosis: OIH presents with increased opioid requirements, pain worsens with increased opioid doses, increased pain sensitivity over time. Opioid tolerance presents as progressive lack of response to opioids, resulting in increased opioid requirements. Pain improves with increased opioid doses. There is no increase of pain sensitivity over time. Acute opioid withdrawal presents with increased opioid requirements. Pain improves with increased opioid doses. There is no increase in pain sensitivity over time. Mechanisms for OIH: opioid-mediated sensitization of pain signaling pathways. Mechanism of opioid tolerance: desensitization of pain signaling pathways of opioids, resulting in loss of potency of opioids. Mechanism of acute opioid withdrawal: removal of opioid effects precipitates a withdrawal syndrome due to spinal reflex hyperexcitability and increase in the rate of firing of noradrenergic pathways emanating from the locus coeruleus. Dose-effect relationship: for OIH, there is a downward shift of the dose versus effect relationship. For opioid tolerance, there is a right shift of the dose versus effect relationship. For opioid withdrawal, the dose-effect relationship is unchanged. Therapy for opioid-induced hyperalgesia: opioid rotation, opioid downward dose titration or cessation, use non-opioid based analgesia such as regional anesthesia, and NMDA receptor antagonists such as ketamine. Treatment for opioid tolerance: increase opioid dose, use long-acting opioids. Opioid rotation, use non-opioid based analgesia. Treatment for acute opioid withdrawal: increase opioid dose, opioid rotation, alpha-2 adrenoceptor agonists such as lofazidine, long-acting MOP agonists such as methadone and buprenorphine, and NMDA receptor antagonists such as ketamine. Prevention of OIH: avoid exposure to high intraoperative opioid doses and other precipitants listed above. Use non-opioid based analgesia. Prevention of opioid tolerance: this might be preventable by use of lower intraoperative opioid doses. Use non-opioid based analgesia. Prevention of acute opioid withdrawal: avoid abrupt offset of opioids. Avoid underdosing of opioids, especially for patients with chronic opioid therapy. Management of OIH. Hyperalgesia in the immediate postoperative period is associated with the development of chronic post-surgery pain syndromes. Thus, OIH should be managed promptly. To prevent OIH postoperatively in patients receiving remifentanil-based analgesia, administer morphine 0.1 to 0.25 mg per kg 45 to 60 minutes before the end of the surgery. Consider adding a low-dose ketamine infusion 10 to 30 mg per hour. OIH can be reduced by various drugs such as ketamine, propofol, alpha-2 adrenoceptor agonists, COX-2 inhibitors, and switching to another opioid such as methadone, which is also a weak NMDA receptor antagonist. Thermoregulation is impaired by opioids and is seen with volatile anesthetic agents as well. Immunosuppression may occur with long-term opioid use. The pharmacological significance of opioid-induced immunosuppression is not yet clear. The endogenous opioid system may be important as a link between the nervous system and immune system. Chronic opioid use in patients suffering from AIDS may exacerbate immune deficiency. Endocrine effects. Opioids increases the pituitary release of ADH, GH, ACTH, and prolactin, and decreases the pituitary release of gonadotropins and TSH. This may result in impaired adrenal function, infertility, and other effects. Serotonin syndrome. This syndrome is associated with fentanyl, petidine, pentazocine, dextromethorphan, and tramadol. A video on SS will be made in the near future. Placental transfer. Opioids are readily transported across the placenta, and respiratory depression of the neonate can occur. Breast milk transfer of opioids. The amount of opioid transferred into breast milk depends on various PK and PD factors. Generally, opioid use for pain management during labor and delivery and subsequent use are compatible with breastfeeding, as long as the opioid treatment duration is limited to 2 to 3 days. However, newly initiated and prolonged maternal opioid therapy must follow a close monitoring program of opioid-naive infants for dangerous adverse effects of opioids, such as respiratory depression. These are my references. Thank you.